Idioventricular rhythm, or IVR, is an abnormal heart rhythm originating in the ventricles, the heart's lower chambers. It occurs when the heart's natural pacemaker, the sinoatrial node, fails to initiate an electrical impulse, or when that impulse is blocked from reaching the ventricles. In IVR, the ventricular cells themselves take over the role of pacemaker, albeit at a slower rate. This rhythm is considered an escape rhythm because it emerges as a backup mechanism to prevent the heart rate from dropping dangerously low. While IVR can be a life-saving response in certain situations, it can also signal an underlying cardiac issue that requires attention. Understanding the implications of IVR, recognizing its characteristic features on an electrocardiogram, and knowing when to intervene are crucial for healthcare professionals involved in cardiac care. Idioventricular rhythm presents a distinct pattern on an ECG, characterized by several key features. The most prominent is a wide QRS complex exceeding 120 milliseconds in duration. This widening reflects the abnormal spread of electrical activation through the ventricles. The rate of IVR typically ranges from 20 to 40 beats per minute, significantly slower than the normal resting heart rate. This bradycardia can lead to symptoms such as fatigue, dizziness, and shortness of breath. The rhythm itself is often regular, although slight variations in timing may be observed. Another characteristic feature is the absence of P waves preceding the QRS complexes. P waves represent atrial depolarization, which is absent in IVR as the impulse originates in the ventricles. Occasionally, fusion beats may be seen, representing a blend of electrical activity from both the sinus node and the ventricles. Idioventricular rhythm can arise in a variety of clinical settings, often as a consequence of underlying cardiac disease. Acute myocardial infarction, particularly involving the inferior wall of the heart, is a common scenario associated with IVR. Reperfusion therapy following a heart attack, either through thrombolysis or percutaneous coronary intervention, can also precipitate IVR. This is thought to be due to the sudden restoration of blood flow to previously ischemic myocardial tissue, leading to transient electrical instability. Other conditions that can predispose to IVR include myocarditis, electrolyte disturbances such as hypokalemia and hypomagnesemia, and drug toxicity, particularly from medications that prolong cardiac conduction. Recognizing these potential triggers is crucial for prompt diagnosis and management. Section 4. Assessing the need for treatment. The need for treating idioventricular rhythm depends largely on the patient's clinical stability and the presence of associated symptoms. In hemodynamically stable patients without significant symptoms, observation may suffice. However, if IVR is accompanied by hypertension, chest pain, altered mental status, or other signs of inadequate cardiac output, immediate intervention is warranted. Treatment typically involves addressing the underlying cause, such as reperfusion therapy for acute myocardial infarction or electrolyte correction for electrolyte disturbances. In some cases, temporary pacing may be necessary to increase the heart rate and improve cardiac output. This involves delivering electrical impulses to the heart through electrodes placed on the chest or inserted into a vein leading to the heart. Section 5. Potential risks of rhythm suppression. While suppressing idioventricular rhythm might seem intuitive, it is crucial to recognize the potential risks associated with such an approach. Lidocaine, an antiarrhythmic drug often used to suppress ventricular rhythms, can paradoxically worsen bradycardia in the setting of IVR. This is because lidocaine suppresses ventricular automaticity, potentially further slowing the already slow heart rate. In patients with IVR as an escape rhythm, suppression can lead to asystole, a complete cessation of electrical activity in the heart, which can be life-threatening. Therefore, the decision to suppress IVR should be made cautiously, weighing the potential benefits against the inherent risks. If suppression is deemed necessary, close monitoring for adverse effects is paramount. Section 6. Management of hypertension and cardiac arrest. In situations where idioventricular rhythm is associated with hypotension or cardiac arrest, prompt and aggressive intervention is crucial. If the patient is hypertensive but conscious, intravenous fluids should be administered to improve blood pressure. If IVR deteriorates into ventricular tachycardia or ventricular fibrillation, immediate defibrillation is warranted. Epinephrine, a medication that increases heart rate and contractility, may also be administered to improve cardiac output. Addressing reversible causes such as hypoxia, hypovolemia, and electrolyte imbalances is equally important in managing these critical situations. Section 7. Key takeaways. Navigating idioventricular rhythm. Idioventricular rhythm is a complex cardiac arrhythmia that necessitates a nuanced approach to management. Recognizing its characteristic ECG features, understanding its clinical implications, and knowing when to intervene are paramount for optimal patient care. While IVR can be benign in some cases, it can also herald a serious underlying cardiac condition. Treatment should be individualized based on the patient's clinical status, with a focus on addressing the underlying cause and maintaining hemodynamic stability. Avoiding unnecessary rhythm suppression, particularly with agents like lidocaine, is crucial to prevent potentially life-threatening bradycardia or asystole. In cases of hypertension or cardiac arrest, prompt and aggressive intervention is essential to optimize patient outcomes.